Okay, well, I'll introduce myself. Hi, everybody. You probably know me. I'm John Ducas, one of the cardiologists at St. Boniface Hospital, and also I go up north. And I just came back from Norway House. I was in Rankin Inlet the week before, into Garden Hill 2 weeks ago, and I'll be in Percy Moore in a couple of weeks. So I know a little bit about the north and some of the challenges in working remotely. I gave one session about 2 months ago or so about the ACS network and some of our changes and vectors and how to manage patients with acute coronary syndromes, STEMIs and non-STEMIs. And this is a kind of a parallel lecture, little slightly different format, still using Slido to go over some ECGs. And let's do that. Let's start. So it'll be interactive. We'll have questions and answers. I'll use Slido, and you can use your phone or your computer. And this is how you join, either logging into slido.com and using that particular number, or you can simply use your cell phone and use the QR code to get into this. And we can do a little experiment with the first question, which is, where do you usually work? So why don't we give this a try and see if it actually functions? Go ahead and answer. Okay, so it's actually working. And we can see most people are working in the Northern Health region and in a nursing station. Well, some work in a nursing station. A few work in Prairie Mountain. Okay, let's keep going. There's a chat question. Uh, okay, fine. So let's get back to where we were. So what do I want to do tonight? I want to review some of the diagnostic criteria for a STEMI. I want to review a few cases, and some of these cases actually I've seen a few days ago, so they're fresh in my mind. We'll talk a little bit about STEMI mimics. We'll differentiate a little bit between STEMIs and STEMI mimics, and we'll review a few simple arrhythmias that might be present. And of course, I'll be happy to answer any questions that you may have. Okay, we'll go forward. Slide, there it is. So just to do a little bit of background, it's important to remember what we mean when we're talking about a STEMI, a non-STEMI, and really the MI part of it stands, of course, for myocardial infarction. But there's actually a pretty strict definition of when you should pull out those words. When should you call somebody a STEMI, a non-STEMI? When should you say they've had a myocardial infarction? Well, by far, the most important criteria is that they have to have a rise and fall in troponin. If they don't have a rise and fall in troponin, they're not a STEMI or a non-STEMI. So currently in Manitoba, the recommended reference range, the upper limits of normal for the ISTAT, which you're probably using in remote areas, is 0.08. And for the in larger centers with the high sensitivity troponin, it's 1 to 14. Notice the different units. One of them is nanograms per milliliter, the other is per liter. And the other thing is that this particular one, the cardiac troponin T, this is the Manitoba reference range. The manufacturer actually is a little bit more generous, and for males, it's actually up to 20. In any case, you have to have the increase in troponin, and very important, you need one of the following: either new ischemic symptoms, which basically is chest pain, or you need to have new STT wave abnormalities or new Q waves or new left bundle branch block. So we really shouldn't be calling a troponin rise a STEMI or a non-STEMI unless you have one of these two things. Now, you might point out to me correctly that there's two other criteria too, which are a little more specialized, which would be a new regional wall motion abnormality, which you might be doing with a point of care ultrasound or a formal ultrasound, or new coronary thrombus on a coronary angiogram. But again, this is something that's not practical for somebody that's dealing with the patient up north or far away. And by far and away, when you're using the term STEMI or when you're using the term non-STEMI especially, you need to have symptoms, you need to have ECG abnormalities. Now, you're going to say to me, well, there's a lot of patients with the troponins that don't have chest pain or don't have new ECG changes, and you're absolutely right. And these, with the patients with the troponin elevated, but no myocardial infarction using this definition, the right thing to call them is myocardial injury. And there's lots of patients you've seen with this. I'll give you an example of troponin up but no myocardial infarction. I'm sure everybody knows that somebody that has chronic kidney disease, creatinine's 200, their troponins are always a little bit up or often a little bit up without chest pain ECG abnormalities. Acute heart failure, somebody can come in with pulmonary edema and no infarction, and the stress and strain on the heart can cause the elevation of the troponin without a true infarction. Sepsis, critically ill patients, even running a marathon. And there's been research looking at this where people get their blood tested, healthy people that have just completed a marathon, and their troponins are significantly elevated. And they're not having a non-STEMI, they have this myocardial injury. And cardiac contusion or shocking patients, defibrillator shocks, likewise. And there's some other things that have listed on this particular table. So new ST elevation at the J point in contiguous leads is the criteria for significant ST segment elevation. So what am I talking about here? Well, in the limb leads, in women or in men, 1 millimeter of ST elevation is all you need. In the V leads, in the precordial leads, the women can get up to 1.5, and young men can even have as much as 2.5 and still be within normal and something that you would not consider as being a STEMI. So also something very important to note is in the 15 lead ECG, when you do the RV lead before R or the posterior leads V8, V9, the requirement for abnormal is down to 0.5 millimeter. So even a tiny amount of ST elevation in these additional leads is considered significant for cardiac ischemia. And when you're looking at one of these ECGs, it's important to understand which segment you're comparing the ST segment to. And it should not be the PR segment, which is the time after atrial depolarization and during atrial repolarization. The heart is still technically active there. The time that the heart is inactive is the TP segment after the T wave and before the P wave. So when you're comparing ST segments, it should be to these TP segments, not the PR segment. Now, we'll ask our first question here. Take a look at this and tell me how much ST elevation do you think? I'll put the poll up in a minute, but look at it for a moment. This is going to be these will be the choices you'll have. I can't quite do the choices at the same time, but look at this. Is this 0.5, 1, 1.55, et cetera, just like that. So I'll put up the poll now, and you can choose what you think that is. Okay. So we have up to about 7 people. Most people thought it was 1 millimeter. Okay, let's take a close look. I've magnified this up. I've put 1.5, 1, etc. And I moved the 1 and the 1.5 out on the TP segment. And you can see that this is between 1 and 1.5. So you have to sometimes be very careful, look very closely at it. and again, with the reference point of the TP segment. Now, the shape of the ST segment is important. Uh, the, the typical characteristic for ST elevation in a STEMI in cardiac ischemia is the convex one, the frowny face one. Here's an example. This is about 80 to 90% of all STEMIs. It will have this type of convex. They're less common, but straight, horizontal, or downsloping is also something that you would see. But by far and away, this is the most common. The concave, the smiley face one, it's unusual that this is a STEMI, but not impossible. About less than 15%. And it's usually early on, and eventually they end up looking like this. So can't say for sure it's not when it's concave, but it's almost always is when it's convex. I'm sure you all know this. I'm not going to belabor this. You know, there's localization in lead 1, AVL, and V5 and 6 for lateral. The inferiors are 2, 3 AVF. The anterior anteroseptal is V1 to V6. And off by itself is AVR, which is a kind of a controversial lead. Sometimes it means left main, though usually it does not if there's ST segment elevation there. Now, it's good to understand a little bit about reciprocal changes. People talk about reciprocal changes, so I'll try to make this a little simple. Let's think about the leads that you see the MI, the leads that are the ST elevation, and where you might see the reciprocal changes, the ST depression. So looking now at the inferior leads or the anterolateral leads, which means, of course, 2, 3 AVF leads 1 and L. If you have ST elevation in these leads, you almost always, and I'll underline almost always, have ST depression in reciprocal leads. And the reason for that is because the limb leads AVR, AVL, lead 1, V2, lead 3, and AVF, they're all variations of the same interconnections in the frontal plane. So if you have ST elevation in lead 3, you're stuck mathematically from having some type of ST depression in one of the lateral leads because they're all interconnected, these leads. On the other hand, the chest leads, the V leads, are independent. They're in the transverse plane. And you can have ST changes here and not mathematically be forced to have changes or reciprocal changes in the limb leads, which are in the frontal plane. So let's walk through this a little bit. In anterior ST elevation, anterior STEMIs, V1 to V4, V1, V2, because they're totally in a different plane from the limb leads, you typically will not have any reciprocal ST depression. It's in a different plane electronically, except for one thing that you have to be aware of, which is when there's posterior infarction. And here, the ST depression is the sign of the transmural ischemia, which you will often see in leads V1, V2, V3. It's behind the heart. Here's the patient lying on his or her belly. The chest is here. The back is here. The V leads are here. And here is where the infarct is. And here is where you see the ST elevation in lead V8, V9. And because you're having elevation here, you're forced to have electronically, mathematically, ST depression in these anterior leads. So when you see ST depression V1 to V4, or V1 to V3 especially, you really have to be worried that this is a STEMI in the posterior leads. Okay, so that's the preamble. We'll start doing cases. I have about 13 or so cases here, and we'll just quickly do them. And I'll ask you a question about the ECG, and you can answer on the Slido. And at any point, if you want to interrupt and clarify something, please go right ahead and do that. 44-year-old female in the emergency room with chest pain, ECG done as promptly, and this is the ECG. The question you'll be asked is this early repolarization? Is this a lateral STEMI? Is this an inferior STEMI? Is this pericarditis? Is this a normal ECG? So I'll put up the poll in a moment. This is what you have to answer. If you want me to show the ECG again, just yell out and I can go back to it. Okay, so we have a little less than half that voted. Most people are gravitating towards lateral STEMI. Few people think early repolarization. Some people think pericarditis. Okay, this is pericarditis. I've taken the patient's ECG and I've chopped it up and I put the lines out on the TP segment so you can see some of the features. First of all, remember to be cardiac infarction, you have to have ST elevation in contiguous territories. And in this patient, it's involving non-contiguous territories. There's ST elevation in lead 1, in lead AVL, and in an inferior lead in lead 2. And there's ST elevation in V2 and V3, which is not a lateral part of the heart, it's an anterior part of the heart. And there's also some mild PR depression. There's a problem with the repolarization of the atria in this lead, which is one of the limb leads. And also there's a little bit of PR elevation in lead AVR. So this is consistent with pericarditis. The patient had sharp pleuritic pain, dyspnea. Her troponin was up. She actually had a coronary angiogram and it showed normal coronary arteries. So here's another example, which is a lot easier to see. ST elevation leads 1 AVL, but non-contiguous ST elevation in lead in 2 and also in the anteroseptal leads. So it doesn't make sense. If it was just 1 AVL and B5 and 6, it would be contiguous. But since you see it in 2, then that doesn't make sense. Plus you see PR elevation in lead AVR. Again, a finding that you will see in pericarditis. You see a little bit uh, in PR depression in lead 2. If there's some questions, I have trouble seeing them when I have my full screen on. So just interrupt. You can unmute yourself and ask a question. That's fine. Let's see. Oh, somebody wanted ECG again. Yeah, this is a smiley face. That's correct. And if you, like I said, you can unmute yourself if you want. I don't mind. Let's go back. Okay, here's another example of pericarditis, ST elevation in the inferior lead, and also out here in V5 and 6, that could be contiguous, but you can see a little bit of PR elevation. And again, this smiley face type of ST elevation. Why do people get pericarditis? Well, we don't have time to get into it, but there's idiopathic, viral, autoimmune, it's often seen in cancer, often in renal failure. And it can happen after a myocardial infarction. In the first 3 days after a STEMI, it's not unusual to get a little bit of pericardial problems, inflammation. Likewise, after cardiac surgery, it's very common. And sometimes you can have a late autoimmune Dressler syndrome. It's usually 3 weeks, 6 weeks after an infarct or cardiac surgery. You really want to have 2 out of 4 chest pain, a rub, these type of ECG changes or PR depression, worsening infusion. And always keep in the back of your mind that the patient could suffer from tamponade. Always make sure there's no tachycardia, there's no pulsus paradoxus, there's no shock, because that's always a worry in somebody that comes with a potentially benign problem, could actually be quite significant. Okay, here's case number 2. 68-year-old, acute chest pain 30 minutes ago. His ECG 6 months ago was normal. His blood pressure, he's having chest pain. His blood pressure is 105, heart rate 102. His chest is clear. His EMS does this ECG. These are going to be the questions you're going to have to choose from. Is this bifascicular block? Is this sinus tachycardia? Is this an anterior infarction? Is this all of the above? So take a quick look, and I'll put up again the questions. So you can start voting.
Can you show us the EKG again?
Yep. Okay, I'll go on. Oops. So somehow, okay. Unfortunately, the answer slides disappeared. This was all of the above. This is a patient that really should make you nervous. A patient like this that's borderline hypotensive, borderline tachycardic, and also has new conduction system disease. His ECG was normal 6 months ago, and now he's got right bundle, he's got left axis. This may well be acute. This is potentially a very sick patient. This is a patient that you really have to be concerned about. And this, again, is something that the ECG can help you understand how ill this patient is. And also, by doing the ECG promptly, you can address this time as muscle problem and try to institute reperfusion therapy. So the axis is leftward to the point that you can diagnose left posterior hemiblock. The patient clearly has right bundle branch block. You can see his rabbit ears in here in lead V1, a widened QRS, and you can see the ST elevation that's kind of horizontalish and quite significant in lead worse than V4. Okay, here's number 3. So this is a 40-year-old man. He presents to the emergency room with 20 minutes of chest pain. He has no previous cardiac disease. And he has this ECG. And I'm going to, because it's not 100% clear, I will say, assuming this is, it's a wide complex tachycardia, assuming this is ventricular tachycardia, is this a STEMI? Or again, because you can't clearly see P waves, but let's assume that this is sinus tachycardia. Assuming this is sinus tachycardia, is this not a STEMI? Or the third choice is, assuming this is sinus tachycardia, this is a STEMI. So here's a patient with a wide complex tachycardia. If you think it's ventricular tachycardia, could you still call it a STEMI? If you think this is sinus tachycardia, could you say it's probably not a STEMI, or would you say it probably is a STEMI? I will put up the choice here that you have, and we can go and vote. Shouldn't be afraid of voting. It's totally anonymous. I have no idea who's voting for what. Oh, there's a question that comes up. I can't see any too many messages. I'm not sure if there's any comment there. So we've got 8 people voting. We're up to 11. Okay, we can go to the answer and we can see what's going on. Okay, assuming this is sinus tachycardia, this is a STEMI. And I'll just walk through this again and to explain why. The first one is assuming this is ventricular tachycardia. It's a wide complex. I can't be 100% sure if it's sinus tachycardia with left bundle or just ventricular tachycardia. But the point here is you can't diagnose a STEMI in somebody that has ventricular tachycardia. There are no criteria that exist. So maybe it is, maybe it isn't, but you can't be sure. It would not, it would be a very difficult argument to support this as VT and a STEMI. If you say this is sinus tachycardia and this is not a STEMI, well, there are criteria you can use in left bundle branch block, which is the pattern that we see here, to decide whether it is a STEMI or it isn't a STEMI. And I'm sure you've heard of them, the Scarboza criteria. So let's just forget that this is ventricular tachycardia. I don't think it is, but I can't say for sure. Let's assume this is sinus tachycardia, and let's apply Scarboza's criteria to it. So here we go. We'll go to Scarboza. So the first thing for Scarboza is somebody that's having chest pain, left bundle branch block. Just 1 second. Okay. Chest pain, left bundle branch block, and you see concordant ST elevation of greater than 1 millimeter in a positive QRS complex. So here is a positive QRS complex. Here is the ST elevation greater than 1 millimeter. So that's one of the 3 Scarboza criteria. The second is concordant ST depression in the V leads. So in the V1, V2, V3 leads. So you see concordant the same way as the concordant with the S wave, and there is more than 1 millimeter. The way I remember this is up and down. Concordant up 1 millimeter or concordant down in V1, V2. And the final one is excessive discordant ST elevation, where the ST to the S ratio, which I've drawn out here. There's the ST, there's the S ratio, is greater than 0.25. So this is 6 millimeters, this is 15, you do the division, and that's greater than 0.25. In other words, the ST elevation is more than a quarter of the depth of the ST depression. Now, why do we need Scarboza criteria? You know, in the olden days, it used to be that chest pain and presumed new left bundle branch block equals this is a STEMI. Well, in point of fact, that's only true in the minority of such patients. And you really often don't know whether it's new or not new left bundle branch block. And so using the Scarboza criteria, you have a good handle on how to segregate out the potential left bundle branch block STEMIs from the left bundle branch block that's not a STEMI. Scarboza criteria are highly specific, but they're not that sensitive. So if you meet Scarboza criteria, STEMI is likely. If you don't meet them, STEMI is not ruled out, but the likelihood of an acute occlusion is lower. And new or presumed left bundle branch block is no longer considered a STEMI equivalent. Many patients with new left bundle branch block do not have an acute occlusion. Now, when somebody comes in with left bundle branch block and chest pain, you have to understand the clinical presentation of the patient to make the best choice. And you should be suspicious for an acute occlusion if they've got a story that sounds like a STEMI, acute persistent chest pain, ischemic sounding chest pain, especially if they have hemodynamic instability. By that I mean their blood pressure is kind of low, or especially if their ST changes are dynamic. These ST segments in the left bundle pattern are kind of changing a bit, or if their troponin goes up and goes up even higher or falls. You may get some assistance if you're capable of doing a bedside echo to look and see if there's any wall motion abnormality, regional wall motion abnormality. And even if there's no Scarboza criteria, if the patient has enough of these criteria, or at least these factors present, then you really should initiate reperfusion if there's a left bundle branch block and you have high suspicion despite negative criteria. Here's case number 4. 71-year-old female, 30 minutes at 10 out of 10 chest pain. She has syncope. She has nausea. She calls 911. Her blood pressure is 80 on 40. Her heart rate's 52. EMS does this, ECG. These are the questions I'm going to be asking that you're going to have to choose from. This is likely a STEMI from a circumflex artery occlusion. The ECG pattern suggests anterior ischemia. The hypotension is not due to the size of this infarction. Atropine should be administered right away. So is this circ? Is this anterior ischemia? Is there more to this hypotension than just this infarct size? Or is this just atropine and don't think about it? Okay. Oops. Okay, here's the right answer. The hypotension is not due to the infarct size. Inferior STEMIs, about 20% of them have bradycardia and hypotension. And this is due to one of two things. It's due to either ischemia of the conduction system, which is often supplied by the right coronary artery, which is the culprit in inferior STEMIs, or by a reflex called the basal-Yarish reflex. Now, you can think of the basal-Yarish reflex as a super-duper carotid sinus massage. It's kind of the same thing, but instead of massaging the carotids, this is a problem with stretch receptors in the posterior wall of the left ventricle. So this is a cardiovascular reflex. It's triggered by stimulation of mechanoreceptors in the inferior posterior wall of the LV during ischemia and infarction. And it leads to hypotension from a combination of vasomediated or parasympathetic mediated bradycardia and vasodilation, which is due to a withdrawal of sympathetic tone. And these patients often do not have a large infarct. So they're not cardiogenic shock because of massive LV damage. They're hypotension, vasodilation, bradycardia, because they're essentially getting a super duper carotid sinus massage, though it's mediated through this stretch of the left ventricular wall. Now, what do you do for this? Well, it depends on how much of this is hypotension and how much of this is bradycardia. So the vital signs help you decide. Atropine is something you can do for the bradycardia. You can give 0.5 3 times. This patient's not particularly bradycardic. And what's driving this patient is the hypotension, the vasodilation. So here you'd probably be more interested in giving some fluid, especially balanced fluid like Ringer's. Now, There's an old wives' tale that you should not give nitroglycerin in all inferior infarctions. That's not true. You should not give it in these inferior infarctions that have this reflex, but there are some inferior infarctions where the patient's quite hypertensive. And if the patient's hypertensive, it can be useful. Sometimes you have to do temporary pacing, especially if the bradycardia exists. And sometimes part of this process is right ventricular infarction. And again, fluid also will help. Though this is often, as I said, a reflex. It can sometimes, as I said also earlier, be direct ischemia of the AV node, but usually it's just a cardiac reflex. Here's another patient. Case number 5. 33-year-old male presents to the emergency room with syncope after giving blood. He's short of breath, he's weak, and he has this ECG. And what I'm going to be asking when the poll comes up is this an inferior STEMI? Is this pericarditis? Is this benign early repolarization? Or is this left ventricular hypertrophy? So here's the ECG. Those are your choices. I will switch to the poll now. So we're up to about 10 votes, about half. I don't know if there's a question here or not. 14 votes.
That person is just answering. Apparently, they don't have access to Slido.
Oh, okay, I see. Okay, so the correct answer here is early repolarization. This is a young male. It's often in young males. It's widespread concave smiley face, and that's kind of what it's like here. You have a high takeoff of the J point, and you often have a bit of a notch there at the J point. And these are all the characteristics of benign early repolarization. He gave blood, he had a vasovagal attack, he comes in not feeling well, he has benign early repolarization, and people have to interpret the ECG. Prominent T waves concordant with the QRS. There's no reciprocal changes to suggest an occlusive MI. It can look like pericarditis. It can look like an acute MI. One of the things is it's not fixed and it can change over time. It would be so much easier. Life would be so much simpler if you get their old ECG and you see the same changes. The problem is with benign early repolarization, it can actually change from day to day. So the presence of it or the absence of it doesn't really, or at least the absence of it before, doesn't help you. And things like autonomic tone, time of day, heart rate, exercise, even body temperature or electrolyte abnormalities can all make early repolarization more or less prominent. Here's the next case. We're more than halfway through. We're almost halfway. 88. Got some diabetes, hypertension, dyslipidemia. She has an unwitnessed fall. She's on warfarin for mechanical AVR many years ago. She's on warfarin for a mechanical valve. When she comes in, she's a poor historian. She's weak. She's slightly obtunded, or at least slightly Glasgow Coma score is a little low. And here is her ECG. Is this due to an electrolyte abnormality? Is this due to Welland syndrome? Is this due to a non-STEMI? Is this due to intracranial bleeding? Is this due to pericarditis? I'll give you the poll here. So an elderly lady, slightly confused, big, deep negative T waves everywhere. Okay, most people are thinking this is Welland. Some people think this is electrolyte abnormality. There's a handful of 3 people thought it was intracranial bleed. What's the right answer? This is intracranial bleed. This is also called neurogenic T wave changes. So what happens here? There's a sudden elevation in intracranial pressure. There's massive catecholamine surge. There's intense sympathetic stimulation. There's what is called a neurogenic stunned myocardium. It is a form of stress cardiomyopathy. You get deep symmetrical T waves, prolonged QT, sinus bradycardia. Here is this patient, and here's Welland's. They're kind of the same, except here the T waves are negative everywhere. Here the QT looks much worse than this neurogenic one. QT can be prolonged with Welland's for sure. You can have quite deep T waves, but it looks a little bit worse on this upper one from this particular patient. And of course, Welland's has often a very tight proximal LAD, and these people, the coronary arteries are usually normal, or if they're abnormal, it's just an incidental finding. So yes, always be worried about Welland's, always be worried there's a tight proximal LAD, but when you see a confused person with these abnormalities, it's probably because of something going on in their brain. So I talked about Welland's, I'll go to the next one. So here's case number 7.
Can I ask a question? Sorry.
Of course, of course.
So with this intracranial bleed, and the difference between valence is in valence, we probably will have a raised troponin. Will we have a raised troponin in this case or no?
You can, yes, and that's because of this this catecholamine-induced myocardial stress. So it would not be surprising to have a troponin elevation with the neurogenic T waves.
Thank you.
Yeah. Okay. So case number 7, 85-year-old, shoveling snow, gets palpitations, gets a little bit of chest discomfort. Vital signs, heart rate's a bit up. He's 6 months post LAD PCI for STEMI. He's got some hypertension, diabetes, mild renal dysfunction. He's on some aspirin ticagrelor, and he has this ECG. He's going 110. Is this an atrial tachycardia? Is this atrial fib? Is this atrial flutter variable block? Is this just sinus arrhythmia? So take a look at that. Atrial tach, atrial fib, flutter with variable block, sinus arrhythmia, and you can vote. Okay, I think most people are getting it correctly. It is atrial fibrillation. There's background fibrillatory waves. For flutter, you would want to see really a sawtooth pattern, especially in lead 2. We don't see that here. It's irregularly irregular. It's narrow complex. So he's a patient that had a STEMI a few months ago and got atrial fib. And of course, the real problem is what to do about his aspirin and ticagrelor, but we don't have time for that. The next case. 61, female, chest pain shortly after syncope. Blood pressure's low, heart rate's low. EMS does this ECG. So I'm going to ask you, is this a inferior STEMI with 2nd degree Mobitz type 1 block? Is this an inferior STEMI with 2nd degree Mobitz type 2 block? this is not a STEMI, but it's third degree block, or this is a STEMI and it's third degree block. So is it a kind of type 2 with a STEMI, or is it a third degree, either STEMI or not a STEMI? So I will put up the poll.
Can you please show the ECG again? Sorry.
Of course.
Thank you.
Okay. So the answers were no STEMI, but third degree, and yes STEMI, third degree. There's another one here, kind of a tie. Well, the correct answer is it's an inferior STEMI with third degree AV block. And here's an example of ischemia in the AV node causing third degree block. There was ST elevation quite clear in the inferior leads. I'll go back to it right here. ST up, ST clearly up, ST up. And you see these P waves. Oops. You see the P waves here in red.
Yeah.
And the QRSs in blue, and they're not related to each other. They're dissociated.
Yeah.
Okay. So independent QRSs from P waves. This is some type of junctional escape because it's narrow complex and in the setting of an inferior STEMI. How often do you see this? It's about 1 in 20 inferior STEMIs that have third degree AV block. It's again from RCA occlusion and ischemia of the AV node. It'll often go away by itself. Only about 10% need a pacemaker. Atropine sometimes works sort of 50-50, and about 3 out of 4, you put in a temporary wire or you transcutaneously pace them. But like I said, usually within a few days, it all goes away. Here's the next case. We're getting close to the end. So 55, male, end-stage renal disease on hemodialysis, presents with chest pain, multiple comorbidities, not complying to meds. He's missed dialysis a couple of times, and he comes in with this. So this is a 12-lead ECG. You can see the V rhythm strip at the bottom, a single channel. The question I'm going to ask is this ventricular tachycardia? Is this a non-sustained paroxysm of atrial fib? Is this a little shot of torsade de pointe, TDP? Or is it none of the above? So here's the ECG. There's something obviously going on here. What is it? VT, AF, TP, TDP, or none of these things? Here's the poll. No, we've had more votes for this one than any of the others. We're up to 14, and it's 50-50 right now. TDP or none of the above. And, oh, TDP is winning now. Okay, here's the answer. It's not going forward. Sometimes the slides stick. There we go. The answer is none of the above. And the answer is hidden behind the rest of the ECG, which I covered. This is the part we're worried about, and look at what happens when you uncover the other channels, lead 3 and lead V5. And you can see I put arrows for each QRS. And you can see that these are all simultaneously obtained. that this awful torsade des points type of, section has very clear QRSs marching through it. So this is a bunch of artifact. And always look at simultaneous multiple channels, because you will be fooled sometimes into thinking that there's a ventricular arrhythmia when it's just artifact. Now, I'm going to tell you something that's kind of interesting next. About 3 hours later, this is the same patient. And this is actually the truth. This is the same patient 3 hours later. So the next question is, now is this ventricular tachycardia? Now is this AF? Now is this TDP? Or now is this none of the above? So I'll put up the poll. I'll also tell you that there's no artifact here. This is a true arrhythmia. Okay, again, people are coming out of their shell and voting for this. And actually, most people are voting correctly. Ventricular tachycardia. Oops. Let me go back. And this is, remember, I said he was a dialysis patient that missed dialysis. And this is an example of classic hyperkalemic VT. I couldn't believe my luck when I saw these ECGs, how interesting this particular patient was. And his potassium was high because he hadn't been dialyzed. When you start to get into the 7s, your heart starts to become a real risk. And when you get over 8.5, then you'll almost always have some type of ventricular arrhythmia. I won't go into the treatment of this, but I will point out that often in hyperkalemic VT, it looks like a sine wave. And I'll go back. And when I saw this, I said right away, I've got hyperkalemia, and just because that's the look of hyperkalemic VT, this sort of sine wave. Okay, a couple more. 52, Filipino descent, smoker, comes in because he's coughing and he's got some palpitations and he's got some tightness in his chest and he's dizzy, hasn't had any syncope, he's a little febrile. He even mentions his father died in his sleep at a young age. Doesn't have any other siblings, when you're trying to get his family history. And he has this ECG. So I'm going to be asking you, is this early repolarization? Is this hyperkalemia? Is this an acute anterior STEMI? Is this right bundle branch block? Or is this none of the above? Okay, I'll go up to the poll. If you want to see it again, just shut out. I think you're more inspired by arrhythmias than you are by ECG abnormalities because there's less votes here, but okay, let's so most people think it's an anterior STEMI, few people think it's early polarization, and a few people say it's none of these things. Well, it's none of the above. And you guys ought to pay attention to this one because this is something that's important. This is type 1 Brugada pattern. It's a sort of a pseudo right bundle. The STs are so-called coved. If you look up the word coved on the internet, if you Google it, the first thing that'll come up is Brugada. I'm not quite sure what. Coved kind of means it's concave, though. It's a sort of a frowny face, ST elevation. but in the context of what kind of looks a bit like a right bundle. And in this particular type, type 1, will have negative T waves at the same time. There are other types. There's a type 2, which has got a so-called saddleback shape, or a type 3, which is a deeper saddleback. And the type 2 and type 3 is usually a pattern, and type 1 is often syndrome. And the reason that it's called syndrome is that this is a genetically determined disease. It's a channelopathy. Sodium channels are abnormal, and people often will have sudden cardiac death, especially in sleep. Fever seems to potentiate the ECG findings and the risk of arrhythmias. And the arrhythmias documented are atrial fib or ventricular tachycardia or fibrillation. And so in this actual person, there was a story of his father dying at a young age. So you have to be always worried when you see this kind of right bundle branch block sort of pattern, which I'll show you again here in this patient. Sort of right bundle, ST elevation, is this, and this patient actually was admitted and had an ICD put in. So almost finished. Second to last case. 62-year-old man, left arm pain going on for 90 minutes. The smoker, no previous cardiac disease, and he has this ECG. Chest pain, 90 minutes. Is this peak T waves from hyperkalemia? Is this just non-specific ST depression? Is this a De Winter pattern? What's that? Is this a tombstone pattern? What's that? So those are your choices. Non-specific, hyperkalemic, De Winter, tombstone. Here's the poll. Don't be shy. If you want to look at it again, I'll put it up. Okay, we kind of plateau out at 10 or so, 11. Okay. Some people think it's non-specific. Some people think it's De Winter. What the heck is that? Some people think hyperkalemia. Some people tombstone. The correct answer is, this is important, you guys, and this you have to know about. This is a STEMI equivalent. It's an acute occlusion with no ST elevation. And this is about 2%, which is about 1 in 50 proximal LAD occlusions. And these people come in with ST depression, not elevation, in the V leads. And they also have prominent T waves. And this is the same thing as having a whole bunch of ST elevation and requires immediate reperfusion. And it really has to be understood that this is the same as seeing ST elevation. So I'll show it to you one more time. This is a classic De Winter. This kind of flat ST depression associated with a peak T wave. If you see that, you should be super nervous. Here's, I think this is the last one, or is the second to last one. So 39, post-dental surgery. This actually happened yesterday to me. Not to me personally, but I got this call. 39, post-dental surgery. Anesthetist calls. Guy was having some dental surgery at one of the hospitals, has some ST depression noted on the monitor. At the end of the case, they do this ECG. He's really anxious. His blood pressure is really high. He's got no chest pain, and his troponin is abnormal. Well, it's 26. So take a look at this. I'm going to ask you whether this troponin is okay for his age. Is this
No.
left bundle branch block? Is this
Yes.
just simply left ventricular hypertrophy? Should you watch this guy anymore? Don't give him any aspirin. Is this a type 2 MI supply-demand mismatch. That explains the troponin. So I will let you vote in a moment. So is that troponin okay? Was that left bundle? Is this LVH? Is this, should you watch this guy at all? Is this a
Yes.
type 2? You know, it's interesting because people sometimes get mesmerized by the wrong thing, and sometimes they miss the obvious thing in front of them. And what people are focused in here now is more the troponin, which of course is abnormal. Is it really a type 2 MI? Remember what I said about MIs. You had to have a troponin rise plus chest pain or ECG abnormalities. And he didn't have chest pain. The ECG abnormality is probably old, and I'll show you in a moment why I think so. And the correct answer is actually the second most popular. And I'll show you what. So here were the choices.
Oh,
Okay. Here's the upper limit of normal. Actually, I said the manufacturer will allow 20. This guy had 26. Should never call this troponin normal. It's probably myocardial damage, minor myocardial damage, but it's not a STEMI, a non-STEMI, because there's no chest pain or associated ECG abnormalities that are new. Does this ECG show left bundle? The PR interval here was short. The QRS was long, but the PR was short. And if you look at this there's him, he has a bit of a delta wave here. So this is a kind of a pre-excitation WPW type ECG. And likewise, it's not LVH. And just because he has pre-excitation, as I said, he doesn't have a type 2 MI because you need to have a rise and fall plus one of these things, and he doesn't have that. So what we did was I said yesterday to the anesthetist, I think he's got WPW. I think that's an old finding. It's incidental. I think that you should not ignore the troponin. You should watch him and repeat the troponin. And 4 hours later, the troponin went down. I said, send him home, let him get followed up by his primary care physician. This is definitely the last case here. And this is, again, something I want you to know about. Highly functioning, this is actually a patient from 2 days ago that I was involved in. Highly functioning 93. I actually spoke to her primary care physician who was also on for emergency. She said, this lady's going to live to 105. Chest pain starting 9 hours ago. She comes into the emerge, still having chest pain, blood pressure, vital signs are okay, and her troponin is abnormal, and she has this ECG. So I'm going to be asking, this is the last patient, is this a non-STEMI? Give her some aspirin and ox, etc. Is this a non-STEMI? Give her nitroglycerin and beta blocker to see if it can control her pain. And if no response, if you can't get rid of her pain, call us back. Is this a STEMI? And you should call vectors right away. Well, the GP had already called. Or should you do a 15 lead ECG? So those are the choices. This is a non-STEMI. This is a non-STEMI, but because she's still having chest pain, try to help her with nitro and beta blocker. This is a STEMI, do a 15 lead. That's going to be your choices. You can vote. Last one. I think you're kind of getting it here. Okay, do a 15 lead. Of course, do a 15 lead. Here's the 15 lead. Here's V9, V8. Remember what I said at the beginning, 0.5 millimeters of ST elevation in V8 or V9 is significant. This lady has significant ST elevation in V9, probably in V8. Remember I said the reciprocal changes of a posterior is ST depression in V1, V2, and that's what this lady has. I showed this picture, and I'll now show the corresponding ECG that she had. In V1, she had ST depression. In V2, she had ST depression, maybe a little bit in V3. And in the posterior leads, V9 and V8, she had a little bit of ST elevation. So always remember, ST depression in the anterior leads is a sign of posterior infarction. If you're not sure, do posterior leads. And this is her actual angiogram before and after the angioplasty. Okay, I want to improve my lecture. Give me some feedback. I'm not going to show, and I don't know who's voting for what, but you know, if this is helpful, you let me know. If I should change things, please send me an email, give me some advice. Not enough ECGs, too many ECGs, too much information after the ECG, not enough description of the ECG findings, too long, not long enough. Any feedback would be appreciated. Okay, I'm sorry for going over time. Any comments while you're voting? I'll stop sharing here.
I absolutely love this. I'm a nurse practitioner, and this is a different world than not what I'm used to. I know ACLS, but a lot of what you guys were doing tonight is new to me. So it was very interesting.
Okay, I will make a little point to rest people's anxieties about ECGs. The computer interpretation is very rarely misses a STEMI. It'll overcall things. It's not that good with arrhythmias, but if you see STEMI come up, you should be worried, you know, off the computer thing. So, you know, you don't have to be the world's best ECG interpreter. It's good to know these little tricks. It's good to know the background. It's good to know about atropine. It's good to know not to be fooled by certain things. And that's what I was trying to achieve with this. And again, any feedback you guys can tell me, you know, let me know.
Dr. Ducas, I have one question. Maybe I
Sure.
missed in the beginning regarding the troponin I and troponin T. I is more sensitive, right?
No, it's the T that's more sensitive. So what you have in rural settings and some of the smaller emergency rooms is the so-called I-stat or troponin I. It's less sensitive. The more sensitive one is what you have in the larger hospitals, Selkirk, you know, all the WRHA hospitals, Boundary Trails, Brandon. That's the troponin T, high sensitivity troponin T, which I think Roche is the company. And that is super sensitive. And you can safely diagnose or rule out a STEMI with 1 hour apart blood work with the super sensitive one. If on the second blood draw an hour later, there's no rise in troponin, it's almost never an ACS. You can't say that with the I-stat, with the one in the rural sites. Rural site, it's not negative until it's negative at 6 hours.
So if we do the first I is 0, but ST changes are suspicious, then we have to wait 6 hours to repeat?
6 hours from the onset of chest pain.
From the onset of chest pain. And if I is negative, then we rule out like that?
Then then it has to be interpreted as, could this be unstable angina? Because unstable angina, you don't have, you know, troponin rise. It's just transient ischemia. But if it's unstable angina, it should not be persisting pain. It should be coming and going pain. So if someone has pain for more than about 15, 20 minutes, and it's 6 hours later, a negative troponin I pretty much rules out an ACS. Now, again, you always got to double check with the patient. You know, every time I walk around, I get chest pain. Well, you got to be a little worried about that. But if they're not saying that, if it's not a classic story, it's not an ACS after 6 hours.
Okay.
Dr. Ducas, in the northern area, we have a lot of patients with the CKD or heart failure, and you told that actually troponin will be higher in these patients. Is there any threshold for the troponin in this group of people or no?
No, to interpret troponin, you really want rise and fall, you know, and that's the most important thing about troponin. And it's very useful to have baseline troponins. So somebody comes into the clinic and there's no indication to do a troponin, somebody that's got chronic renal failure or even heart failure, it's a good idea just to draw a troponin so it's in the chart, so that when they come back, you know, a month later or a year later, you know what the usual troponin is in this guy. But remember, you can't call it a non-STEMI unless there's chest pain or ECG abnormalities. You can call it non-specific myocardial injury, and it's common, and it's seen in heart failure, and it's seen in renal failure, and it's very useful to have a baseline. So get a baseline in these people, so when they come in, you know, the next day or the next week, you'll know whether something's changed.
Exactly. I was thinking about that, but about the baseline, for example, if someone has CKD and today is, for example, 100, you think it will be the same 6 months later if no heart problem?
It won't be 100% the same. And you have to also understand that if they develop heart failure on top of the chronic renal failure baseline elevated troponin, the troponin might go up even higher. But don't use the word non-STEMI in a patient like this unless that patient's having associated chest pain or, you know, new ECG abnormalities. It's just non-specific myocardial injury. It's because of just, you know, in the same way that cardioverting somebody or running a marathon will cause a troponin rise, having chronic renal failure will cause a troponin rise.
Okay, thank you.
It's not a coronary event.
Mhm.
Okay.
And also, thank you. It was a great session, and I enjoyed that. And I personally, I believe I need to review the material. So it would be great if you share the slide with us.
I can send you the slides, no problem. Just send me an email and I'll and you can distribute them, Sharush, to
Yeah,
everybody.
sure. Yeah.
And
Send to me,
again,
I will distribute. Yeah.
and again, if there's any suggestions for how I can improve this format, it's the first time I've tried to do this type of lecture this way. And if anybody has some feedback for me, I would greatly appreciate it. So everybody have a good night.
Sorry, Dr. Ducas, one thing
Yeah.
more. Nowadays, now if we have doubt about EKG and we want quick somebody to review the EKG, before we were calling the cardiologist and right away with Tiger Connect, we were, you know, making the photo and sending. Now everything through vector, it's kind of irritative, you know. I want to speak to the cardiologist quick just to show the EKG, how that
Well,
works with the rural.
yeah, well, first of all, vectors is only for emergency patients. So a patient in the hospital or in an emergency room. So if you have a clinic patient or an outpatient and you want an ECG reviewed, yeah, it's not appropriate to use vectors. I think what you really need to do is there is no way now, they will not allow or accept calls to cardiology at St. Boniface anymore. Everything is through vectors. So if you have a patient that's an inpatient, if you have a patient that's an emergency room patient, you can call vectors. You don't have to feel embarrassed about it. It's perfectly permitted. Ask to speak to the outside call cardiologist and review the ECG. If you have a patient that's an outpatient and a clinic patient, well, then you have to have a relationship with a cardiologist and, you know, contact them and ask them to see the, you know, kindly ask them to help you and look at the ECG. But I can't, you know, I can't force them to do that.
Yeah, but sometimes they will call, say I'm not on call, like they are busy also. It's difficult just to
There's
send.
always a cardiologist on outside calls. If you call Vectors and say, you know, I have a consult I want it on an inpatient or emergency room, the cardiologist must respond, not immediately if it's not a STEMI, but it's on the Vectors board and it will stay on the Vectors board until the cardiologist has responded.
Sometimes for the STEMI, they put ER physician for STEMI calls through Vector.
There's 8 STEMI physicians. There's 8 code STEMI physicians. Half of them are ER physicians, half of them are cardiologists. And
Okay.
and in the future, there may even be more emergency physicians. But they all are very familiar with ECGs. So, but that's just the cardiologists are refusing to do code STEMI calls. What can I do?
Mm-hmm. Okay. Okay, thank you. Thank you.
Okay, good night, everybody.
Thank you.